Very good morning to one and all of you. Today I'll be taking class on renal stones and obstructive uropathy. So I start this with a case of a 10-year-old boy who was brought to your clinic who is having a lifelong problem of day and night urinary incontinence. That is, he is micturating or passing urine day and night without his knowledge. Okay. That is, he cannot control his bladder. He reports that he can't pee across the bathroom like some of the other boys at the school. Okay, so boys usually try to do this, how far their urine can go. So that just tells about the force that a boy or a male can put during urination. So if the proper force or distance is not covered, then that means there is some urinary pathology to it. When he feels the urge to void, he has little warning before urine starts to drain through his urethra. That is, he can again not control his bladder. He has history of recurrent episodes of pain in the costovertebral angle with fever. Okay, so all you know from my previous classes and from your own medical knowledge that costovertebral angle signifies usually the renal angle or exactly the place where the kidney is. So if there is a pain in costovertebral angle, you should think about kidney functions or malfunctioning, and if it is a long present associated with fever, that means there is a chance of kidney infection. And it is also further confirmed by the statement that it is relieved with antibiotics. Okay. So there is now some pathology in the kidney and it is relieved by antibiotics. And one thing is that it is recurrent. Okay. Recurrent means there is recurrent pyelonephritis to the patient, okay, recurrent renal infection. So you know that when you give antibiotics, the infection is relieved. But when it is recurrent, that means there is some other cause that is causing there is this recurrent infection. So you have to get to the root cause of the disease. Now here he also has a history of oligohydramnios in fetal period. So if you're in your second UG time, if you didn't have gynecological postings, I'll explain that you know that a fetus in the womb is surrounded by the amniotic fluid. Okay. So when the amniotic fluid, how it is formed is mainly from the urine which is passed by the child. Okay, so the urine which is produced by the child is coming from the kidney only. So the amniotic fluid, if it is normal, it is best for the child. If it is more, you call it a condition called polyhydramnios, and if it is less, it is a condition called oligohydramnios. Okay, so when the kidney of the function is not of the child is not working properly, that means the fetus will pass less urine into the amniotic fluid and hence the amniotic fluid will be decreased. So that is again signifying, and other causes are like dehydration of mother and all also will be total. The body in the fluid in the mother itself is less, then also she can go for oligohydramnios, and in other conditions like hypertension of mother also it can happen. But here when you know the child is having a renal problem, when we are suspecting, even in the womb when the he or she was a child also he is having oligohydramnios, more signifies that there was a congenital problem, okay, in the urinary tract. Now on examination he has raised BP, that means the kidney is obviously affected, because you know in controlling hypertension how much kidney is important. So we did a voiding cystourethrogram to the child. Okay, voiding cystourethrogram means micturition cystourethrogram. That is, while voiding, you are taking this thing. I have said that to know the exact function of the valves, especially you need pressure to apply to the bladder. Then only while the pressure is building, you can know if the valve is not functioning through the defective wall, how the urine is passing and wherever the defects are there. So here also we employed micturition cystourethrogram, and then you can see that there is this, if this is the bladder and here there is a valve which is seen, and after that it is is very narrow. So usually the urethral, this thing shouldn't be narrowed. Okay, but here it is narrowed. That means there is some valve appearing here. So this is a condition called posterior urethral valve, which obviously I have said to or mentioned in my previous lectures also. So in a male child, here there is obviously a prostate below the urinary bladder in the starting point of the urethra, and then the penile urethra happens. So in the after the prostate urethra or inside the prostate urethra, there can be a valve. Okay, so the valve just after the prostate urethra, it is called posterior urethral valve because it's in the posterior position. Usually this valve is not present or gets regressed when the child is developing. But if it persists, then it will be very difficult. See, obviously, if the tract will be obstructed here, and then the urine will get accumulated here in the bladder, and then it will pass to both the tracts, because obstruction is here, both the tracts will be affected and dilated, and then renal pelvic calyceal system is also now dilated. So now if this is not controlled, means 10 years it has become, means both the child's kidney is dilated and it has gone into hydronephrosis, and since the child is having fever and infection, that means it has gone into pyonephrosis or pyelonephritis. Pyonephrosis means there is infection inside the kidney, and if it is filled with pus, okay. So there is hydronephrosis, and then there is uh, pyelonephritis as well to the child. So this should have been ideally detected early in the infant period itself, during routine checkup if it was possible, if the child is maturating properly and with force and all. So if it was detected early, your both the kidneys would have been salvaged, and the technique to remove this condition is only a cystoscopic technique. That is, through the urethra, you will insert a cystoscope and the valve will be resected out. Okay, through a small telescope placed through the penis into the urethra. So that's just, so we are just coming to the proper topic today. What is obstructive uropathy? So obstructive uropathy, as the name suggests, there is obstruction. That is obstructive lesion of the urinary tract. It can be structural or functional. Structural means proper physical obstruction is there. Functional is that nerve impulse is not happening. Because of that, it cannot pass the urine. Okay, that is functional obstruction. So there can be functional or structural obstructive lesions of the urinary tract, and all these come under obstructive uropathy. There is increased susceptibility of infection and stone formation. Why infection? Because the urine is now stagnant because of the infection. Because of the obstruction, the urine is stagnant, so there is a chance that bacteria and all the germs can proliferate and it can get infected. Stone formation, because urine is supposed to excrete all the metabolites, but the if urine is not passing out, all the metabolites get concentrated and accumulated, and they can cause stone formation. Now unrelieved obstruction will invariably lead on to permanent renal atrophy. Okay, that how it is coming, I'll just explain later. So what is hydronephrosis? As you all know, there is dilatation of the renal pelvis and calyces. That is, you know that how does the urine form? Urine is formed from the glomerulus. It is filtered, and then it is going into PCT, Henle's loop, DCT, collecting duct, then renal papillae, then renal pelvic calyceal system, ureter, urinary bladder, and then urethra. So when there is accumulation or obstruction, the urine gets backflowed in the same direction in a reverse way. That is, from the urethra to the bladder, and then to the ureter it will get accumulated, then it will get accumulated in the renal pelvic calyceal system, then it gets accumulated in the tubular system. Okay, and then the kidneys pelvic calyceal system is expanding with the urine, so there is dilatation of the renal pelvis and calyces only with urine or some fluid. It is called hydronephrosis. It is associated with progressive atrophy of kidney due to obstruction of urine outflow. So because of obstruction, the pelvic calyceal system is growing and growing and growing, because urine is getting accumulated. At last, the full kidney will be filled with only urine. Okay, the parenchyma will reduce to very less. That is why kidney will get atrophied. So the obstruction can be at any level. Okay, so if you're starting from downwards to the above, urethra, There can be posterior urethral valve, as I said about this case, and then there can be tumors here like prostate carcinoma, then prostate hypertrophy, and then bladder. There can be tumors, again, calculi, stones, or then functional, that is, nerve impulse is not given to bladder, then there will be functional obstruction of the bladder. Then in the ureter, there can be calculi, tumor, clots, stricture, cancer, everything. In pelvic calyceal system also obstruction can be due to any tumor, stones, or any congenital abnormality also. There are some physiological causes like pregnancy also. See, when you're advising gynecologically or obstetric patients, you will say the pregnant ladies to sleep in a certain kind of position, in a lateral position. Why? Because the ureter, you know that the urinary bladder is situated just behind the bladder. So if the ureter is expanding and expanding, it is going to pressure over the bladder, and then the ureter is in the side and it can cause compression of the ureter. So if ureter is compressed for a long time, then that also can cause kidney problems. Okay. So that also should be kept in mind. And then hydronephrosis, that is dilated renal, pelvic calyceal system, and the kidney. So you have to know where the obstruction site is. Suppose the obstruction site is here. I said both the pelvic calyceal system and the ureter, both sites will be dilated. There will be hydroureter hydronephrosis also. There will be hydroureteronephrosis. Okay. And then if the obstruction suppose is in the pelvic ureteric junction, that is here, so there is only dilatation of the kidney. So there will be only hydronephrosis. Okay, the rest of the kidney and everything will be fine. And if the obstruction is in the unilateral uretrovesical valve or the junction, then only hydroureter and nephrosis of that side. So it directly implies that when you're doing a micturition cystourethrogram, which all parts are dilated, you just check for the causes of obstruction at the point from where the dilatation is there. Okay, so it will just tell to us or lead us to the cause where the obstruction has happened. Bilaterally, if it is there, obviously the obstruction is in the urinary bladder or in the urethra. So open hydronephrosis grading system is there. That is how it gets progressed. So when urine start getting accumulated, first it will get accumulated in the pelvic calyceal system, and the pelvic calyceal system gets expanding and expanding, and it involves all the uh, pelvic calyces with, and then the medulla gets thinned out here, and then later on the cortex also gets thinned out. Okay, so in the first stage, as I have said before also, in the pelvic calyceal system, the papillary tips, okay, renal papillary tips are flattened, okay, at the poles, so it is easier to get dilated in the upper pole and the lower pole. Okay, the kidney has been now kept like this to show and fit into this figure. So you have to just understand this is the upper pole and lower pole. So the poles are getting dilated first, and after that all the pelvic calyceal system will get dilated, and then the dilation will progress and the medullary part of the kidney will be thinned out, and later on the cortex also will get thinned out. And you know the blood vessel of the kidney is through the cortex. Okay, so when the pelvic calyceal system is getting dilated, the arteries here will get compressed, and because of that, the blood supply to the kidney also will get occluded, and at last it will turn out that the renal atrophy will occur fully. Okay, so this is how progressively also renal parenchyma is reduced and reduced because of the dilation of the pelvic calyceal system. Because of that also the kidney gets atrophied and non-functional, and along with that, or to aid with that, or to make it worse, there is this compression of the artery also, the blood supply of the kidney, and then it will progress on to atrophy faster. So, what is the mechanism of hydronephrosis? As I have said, there is high pressure in the pelvis, which is transmitted back through the collecting duct. So, wherever the obstruction is there, the urinary backflow occurs, and that will get urine to get accumulated in the pelvic calyceal system. So, when there is backflow, the tubular system will be affected first, that is collecting duct, and then DCT, loop of Henle, and then PCT. So, when the tubules are affected, the main function of the kidney is, or the tubules is to concentrate the urine. So that is lost first. Okay. So tubules won't be able to concentrate, and then the patient, if he is passing urine, he will have polyuria and nocturia because tubules are defective. So you have to understand that first tubules are affected and then only the glomerular filtration is affected. So glomerular filtration is continuing, that is urine is forming and forming, but only tubules are affected now. Okay, so when what happens then, see, urine is accumulating but there is no space to go. Okay, so what will happen is that because of the obstruction, urine is not passing down, but glomerulus is filtering the blood, and urine is still produced. So all this urine which is accumulated in the tubules will go into the interstitium. Interstitial fluid is ultimately the lymphatic fluid, and that will go into the lymphatic system of the body, which will drain into the jugular vein and directly into the heart. Okay, so the extra urine which is formed, or the urine which is normally formed, also goes into the interstitium and then ultimately into the blood space of our body. So when more urine is there, there is more blood or more plasma. That means there is increased fluid in body. So that will cause hypertension. Okay, because there is more and more fluid accumulation into the blood. And then obviously glomerular filtration rate will fall as the dilatation progresses. I said tubules are affected and later on glomerulus also will be affected. When glomerulus is affected, glomerular filtration rate will fall. And then now, because of these compressions, I said when the dilated pelvic alyssal system expands and expands, the arteries in the periphery or in the cortex will get compressed, and then it will lead on to renal atrophy completely. And because now urine is stasis, there is chance of germ or infection, and then bacterial proliferation, so the patient can have pyelonephritis. All the constituents and metabolites in the urine will get accumulated, so the patient can have urinary calculi, and there is decreased urinary formation later on. Okay, because now all the urine is, because it is obstructed, will go into the interstitium and then ultimately to your blood, so there is more plasma, so you will have hypertension. So what is obstructive uropathy? As I have explained, it is the structural and functional obstructive lesion of the urinary tract. There is increased susceptibility for infection and stone formation, and ultimately, if it is not relieved, it will lead on to permanent renal atrophy. Now, hydronephrosis morphologically, you will see like this. You can see here there is some pelvic ureteric junction. There is some structure happen. Because of that, the urine is obstructed here and it is dilating the whole pelvis and then the calyceal system here. Okay, you can see the medulla is not at all been visible. It is totally thinned out. Cortex is still there little bit. Okay, so medulla is thinned out. It's almost a grade 3 hydronephrosis. So pelvic calyceal system is dilated, and then that is thinning of medulla. Later on there will be thinning of cortex as well. Histologically, if you see, because the interstitium, whenever it is undergoing any atrophy change, it will undergo fibrosis, tubules will undergo atrophy, and glomerulus will undergo sclerosis. Okay, so interstitial fibrosis and tubular atrophy, because tubular interstitial part is the one which is affected the most. Types of hydronephrosis based on how fast it is occurring, it can be acute or chronic, and how much is affected, it can be partial or complete, and which all sites are affected, it can be unilateral or bilateral. Clinical features are, if there is acute obstruction, see the acute obstruction, and then the urine is accumulating so much and so much that kidney is filled with urine. Okay, pelvic alysis system and kidney totally is expanding. So you know that kidney is surrounded by a capsule. Capsule is finite. Okay, it won't expand, but the kidney is expanding now, so it is putting pressure on the capsule, so you will get severe pain. Okay, because of the renal capsular distension. Wherever capsule is there, if the organ is expanding, you will get pain. Okay, same way in the liver also, there is Glissen's capsule surrounding. When liver is enlarging, Glissen's capsule is finite, it won't get enlarged so much, so it is putting traction onto the capsule, so it will cause pain. Okay, so here also there will be renal pain, renal colic, because the distension of the capsule, and depending on the cause, if the calculi is in the ureter, you will get urinary colic. If it is in the kidney, you will get renal colic. And if there is prostate enlargement, you will get symptoms accordingly, that is nocturia, urinary frequency, etc. So it is depending upon the level of obstruction. Unilateral hydronephrosis remains silent for a long period. Like if a person can live with only single kidney, you know that the single kidney, if it is affected to a certain extent, you won't know only because the other kidney will compensate for the same. So unilateral hydronephrosis is that the patient will remain silent for a long period until he is being diagnosed by some USG for other some causes. Okay. But bilateral obstruction will obviously be significant and symptomatic. So in bilateral partial obstruction means only partially obstructing, so urine is still passing. So that time what happens is that the first thing that is affected is tubules. Tubules is has lost the function to concentrate urine, means they will start having polyuria or nocturia. That is dilute urine will be passed. There is no concentration of the urine, so full water is passed out. So partial obstruction may the patient will have polyuria and nocturia, and when there is complete bilateral obstruction, both the kidneys are not functioning and fully obstructed, patient will have oliguria or anuria or no urine is passed. Okay, it is rapid onset and difficult to survive also because patients both the kidney is shut down, there will be fluid accumulation so much in the body. Okay, so it is important to relieve the obstruction by diuresis. Okay, so and what to investigate, I said as before, you will do voiding or micturition cystourethrogram, and x-ray you will do KUB. And then now I said about the same case, 10-year-old boy was brought to clinic. Now, why he is having recurrent renal pain and fever is that he is having recurrent pyelonephritis because the urine is still stasis and both his kidneys are affected because of the posterior urethral valve. So there is obstructive uropathy because of that. Urine is getting accumulated in his bilateral kidney. Okay, and then because of that, he is having recurrent infection. There will be raised BP obviously because all the urine that is formed is going into the interstitium and directing to the blood. So next we will be coming into case number 2. That is today's topic has obstructive uropathy and renal stones. So we will be discussing the second case. 24-year-old male developed left flank pain moderate to severe and hematuria, and he has a history of passing stones for 5 years. Okay, it is a typical history and it is very common for a medical or a medico to um, see in your practice at least some patients of stones, okay, of renal stones or urinary stones, etc. And you yourself also might get stones, okay, if you're not drinking water properly. So hydration is very important. So if a patient of stone presence, his presence mainly due to left or right flank pain, okay, because that is where the kidney is there. And then he will be having hematuria. Why? Because you can see this edges of the stone how sharp it is, so when they are passing through the urinary tract they can cause trauma or injury, and because of that blood can pass through urine. And he's having a recurrent history of passing stones, means the proper cause should be investigated. And then there is history of lithotripsy. Lithotripsy is an operation or surgical procedure used to remove the stones from the body. And then urinary analysis was done for the patient. His pH was 5, which is acidic. We'll let you know about what is the significance of it. And then RBC is 100 to 200. That means he is having good hematuria. Good means it's not good, it is very bad. And then there is calcium oxalate and uric acid crystals. This is uric acid crystal, okay, which sees almost like a diamond shape. And calcium oxalate crystals are well known for its envelope shape, okay. So if you see calcium oxalate crystals and uric acid crystals, just by giving your urine, it is a clue that your stones can be a mixture of calcium oxalate and the uric acid. Otherwise, you can go for further testing like the stone which is passed, you are giving it for chemical analysis. So what the patient was advised was to decrease sodium, and that is salt and sugar in his diet and decrease the oxalate also. And then he was given hydrochlorothiazide and allopurinol. If you know, they are mainly diuretics to pass more water or the pass more urine, so that your constituents and stones can be flushed out of the body. And over the next 2 years, after he took all these dietary tips, he was totally normal and he didn't have any recurrence. So, you know, the cause is there somewhere here. Okay. And maybe the body also. So now we are coming to the important topic, that is urolithiasis. It is a very common disease that you can encounter in your clinical practice. So the most common site for the kidney stone formation is or in the urinary tract it is kidney. Okay, in the ureter also it can form, in the bladder also it can form, but most commonly it is in the kidney, and especially it is in the males, and that also in the age group of 20 to 30 years. Four main types of calculi are there, and they are calcium stones, triple stones, uric acid stones, and cystine stones. Most common one is the 70 percentage, that is calcium stones, which are mainly formed by calcium oxalate with a mix of calcium phosphate. Then there is triple stones or struvite stones, which constitute 15 percentage, and they are comprised of three things. That is why triple: magnesium, ammonium, phosphate. Then you have uric acid stones and cystine stones, which are less common. So first, you should know what is urolithiasis. They are most important determinant, okay, is an increased urinary concentration of stone constituents such that it exceeds the solubility or supersaturation. Okay, so what is saturation? You take a glass of water and then you start putting salt or sugar. Okay, so and then you will put to certain extent, it will be dissolving and dissolving and dissolving. After a certain point, it won't be seen. So that is called saturation. Now, if you're putting more sugar or salt to it, then it starts getting precipitated. So that is called supersaturation. So when you add the constituent or the solute, if water is the solvent, the solute, if you're adding, it will reach a saturation level where it is fully dissolved. Okay, the maximum amount of solute that the solution can take it. And then more, if you are putting the solute, it will get precipitated, and that is called supersaturation. Same way in the urine also, if you are the constituent, which is calcium or phosphate or magnesium, is getting saturated and saturated after a certain amount of level, if the solute or the constituent like calcium is more, then it will start getting precipitated and it will form stones. Okay, and this is called supersaturation. So you have to imagine why low urine volume is important. See, if you're taking a one glass of water, it will saturate certain amount of salt. Okay, if you're taking less amount of water, obviously you will need only less amount of salt to saturate it. So lesser the water, lesser will be the amount of constituent which will be required to saturate. That means the stone will form faster when there is low urinary volume. So that is why dehydration is a very important component. If you are not drinking water properly, there is more chance of stone formation. So, along with that, there are hereditary conditions like hyperoxaluria, cystinuria, hypercalciuria, hypercystinuria, hypercalciuria, hyperuricemia, and hyperuricosuria. These conditions in which the constituent is congenitally increased due to some metabolic defects for the person, and they have higher chance for stone formation also, but these conditions are little rare. So in calcium oxalate stones, okay, calcium stones, 10% of the patients have hypercalciuria with hypercalcemia. So hypercalcemia is that in blood itself the calcium is increased. Because of that, he or she is excreting more calcium in the urine, and that is because of hyperparathyroidism or bone disease or sarcoidosis. Hyperparathyroidism, you know, parathyroid is important for calcium metabolism in our body. So when parathyroid is not functioning properly, or if it is increased parathyroid hormone is there, and because of parathyroid adenoma, etc., parathyroid hormone itself is increased, calcium will increase in the body. So there will be hypercalcemia, they will be precipitated in the urine, and they have calcium stones. Bone disease, if you have bone degenerating disease, you know bone is made up of mainly calcium hypoxidate. Okay, hydroapatite. So because of that, the calcium is also increased in the body because of bone degeneration, and then it can lead on to calcium stone formation. then sarcoidosis also. Then 55% of the cases there is hypercalciuria without hypercalcemia. Okay, calcium in the blood is increased, not increased, but calcium is increased in the urine. Then you have to know how the calcium is metabolism occurs in our body. First is absorption. So calcium is absorbed in from intestine and it is reabsorbed from the kidney also. Okay, when it is passed through the urine, before passing the calcium is reabsorbed for the bodily needs. Okay, so if intestine absorbs more calcium, it will pass more calcium through the urine because body will take how much it requires only. And then if the kidney is absorbing extra calcium, then that also extra calcium goes through the urine itself. Okay, so there is when there is increased amount of calcium absorbed, it passes more through the urine and there is more chance of calcium stone formation. Then there is idiopathic fasting hypercalciuria also. In some patients, if they are fasting too much, the calcium can pass out through the urine. Then if there is raised uric acid or hyperoxaluria. So if in these conditions, if the patient is already having a congenital condition in which he is having increased uric acid secretion or increased uric acid in the blood or oxalic acid in the blood, then that will again help in precipitating calcium oxalate stones. Okay. So you can see the calcium oxide stones are usually yellow brown in colors and with smooth contours, okay, like a cubical shape. And then in the urine analysis you will see calcium oxalate stones. Calcium oxalate stones can be two types, okay. One is this one which is envelope shaped and other there is a dumbbell shaped also. Okay, both the things that suggest that calcium oxalate is the stone which is formed in the urine if the patient is having stones. It's normally also it is possible that you can see so many calcium oxide crystals in the urine of the patient. That doesn't mean every patient will be having stones. Okay. In a stone patient, if you are seeing calcium oxalate, that indicates that the stone is mostly formed by calcium oxalate. Then the second stone is the struvite or magnesium ammonium phosphate stone. So you have to know the very important thing is that the stone is formed in alkaline urine here. Okay, in calcium oxalate, the stone is formed in an acidic urine. Okay, so how magnesium ammonium phosphate stone or struvite stone is formed is that the patient is having urinary tract infection and that urinary tract infection is due to some urea splitting bacteria that are Proteus and Staphylococcus. So when urea is split, it is split into ammonia. Okay, and then this ammonia will precipitate bond with magnesium and phosphate in the urine, and then they form the magnesium ammonium phosphate stones. So it's important that the patient is having an urea splitting bacteria infection, that is Proteus or Staphylococcus UTI is already present, and those bacteria in the urinary tract will split urea into ammonia, and because of ammonia the patient's urinary pH will become alkaline. Okay, and then the urine which has magnesium and phosphate etc., that will combine with the ammonia that is split and formed, and then it will form magnesium ammonium phosphate stones. They are supposed to be the largest stones because the amount of urea excreted is very large in the body. Okay, normally the urea is excreted as such. Okay, but when the bacteria is there, then it is split into ammonia. So this much amount of urea which should naturally pass are getting precipitated by ammonia. So they form large amount. Okay, so it is a larger stone. And then they are also called staghorn calculi because the precipitate formed takes the shape of the renal pelvis. Okay, what is staghorn? Staghorns are the antler horns. Okay, the horns of a certain type of goat which are called antlers. Okay, their horn have a certain pattern. So the stone looks like that because it takes the shape of the renal pelvis. So it is called staghorn calculi. Okay, calculi means stone. So staghorn calculi, or it is a struvite stone or magnesium ammonium phosphate stone or triple stone. Okay. So that was the second, and I said that magnesium ammonium phosphate stones are produced in alkaline urine. Okay, all other stones like that is calcium oxalate stone, uric acid stone, and the cystine stones are formed in acidic urine. Uric acid stones, they are common with hyperuricemia like gout. Okay, so uric acid should be increased. Obviously, in the stone name, the constituent is there that will be increased and that is precipitated and they are forming the stone. So when there is uric acid stone, obviously in the body, somewhere uric acid is increased. So how is uric acid formed? They are the byproduct of purine metabolism. Purine is coming from the DNA of the body. So how will DNA will increase and get metabolized to uric acid when there is high cell turnover? Okay, high cell turnover is seen in usually cancer conditions or maybe skin conditions where there is high turnover like psoriasis, etc. So especially in cancer and when you are giving chemotherapy also there is high cell turnover because all the cancer cells are dying. Okay, that time also you can get hyperuricemia, and otherwise also in cancer conditions you will get hyperuricemia, and these uric acid can precipitate in the acidic urine and form the uric acid stones. Okay, so you should note one point is that calcium stones are radio opaque. That is, in radiology, if you are taking X-ray KUB, you can see white colored calcium stones. They are radio opaque, but uric acid stones are radiolucent. That is, they can be black color or you cannot see it because of the black color. Okay, so the thing is that if a patient is coming and you're suspecting the patient is having stone formation and you're taking the radiology and you're not seeing the stones, that doesn't mean the patient is not having stones. Okay, so there can be that the patient's cause is due to something else, but there is also something to keep in mind that the patient may be having uric acid stones that are missed in the radiology because uric acid stones are radiolucent. So what you will do here, you will either do the chemical analysis of the stone if it is formed, okay, or else you check the urine analysis of the patient, and if you're seeing uric acid crystals so much, then that is pointing towards the patient can have uric acid stones. Then lastly, there is cystine stones, that is this genetic defective patients which are having cystine urea, hypercystinemia, etc. will be having cystine stones that are precipitated in the acidic urine again. So they are looking like gemstones, okay? Such stones are passed through the urine. So only the struvite stones are so large that it is confined to the kidney, and mostly the other stones are smaller and they can pass normally through the urine also. So factors affecting stone formation, I said increased concentration of the stone constituent should be there. pH also in acidic urine, there is calcium, uric acid and cystine stones, and in basic pH, there will be struvite stones. Decreased urinary volume will obviously affect the stone formation. Presence of bacteria, which is important for the magnesium ammonium phosphate stone, and then deficiency of inhibitory factors for crystal formation in urine. Okay, so there are certain inhibitory factors also that prevent from the stone formation in the urine. That is a natural body mechanism. If that is also affected, there is more chance for the stone formation. So urolithiasis, how will be there? You know that urinary calculi will be there. So the patient will have a loin to groin pain. Okay, loin to groin pain will be there for the patient. That is severe pain when you have stones affecting. And then the patient will have blood in the urine, that is hematuria, because of the trauma caused by the stone that is passing. If there is superimposed infection because the stone is obstructing the ureter or kidney or the urethra, then there will be obstruction, then there will be pyelonephritis or hydronephrosis, obstructive uropathy, and all those symptoms can be there. So what you will do urine analysis or chemical analysis of the stones, and then you will do medically manage, that is you give uh, treatment for the infection, and then you will alkalinize the urine if the patient is having acidic urine which is causing the stone formation. If the patient is having alkaline urine, you will do acidifying of the urine for the stone passing. You are doing the opposite. If the patient is having acidic urine, you should alkalinize the urine to pass the stones, and then if you are having alkaline urine, you are going to acidify the urine to pass the stones. Okay, and then you will, that is also one thing which you give if someone had UTI infection, you know that you will be prescribed antibiotics, with along with that you will be given some liquid that is to acidify or alkalinize the urine. And then other managements are, you will do lithotripsy if the patient is not passing the stone, naturally. So one thing is extracorporeal shockwave lithotripsy. So what you will do, the patient is placed like this, and then extracorporeal means outside the body. Shock waves are passed directly onto the site where the stone is there, and then they are powdered or fragmented, and then that fragmented stones pass naturally through the urine. Second is PCNL, that is percutaneous nephrolithotripsy. Okay, so here what happens is that percutaneously we put the instrument, and inside in the kidney, in the renal pelvis, you fragment the stones and then it is taken out. Okay, so in this case, as you see, the patient has had flank pain because of the urinary stones, and it was causing trauma. Because of that, the patient is having hematuria. History of stones, because since the stone is forming again and again, maybe because he is not drinking water again and again, or he is having some hyperparathyroidism which is not treated. Because of that, he is having stones again and again, and he has undergone lithotripsy also, because some big stones are there which is not naturally passed through the urine. And from the constituent, you know that the patient is having urine is acidic, so it should be either calcium oxalate, uric acid, or cysteine stone. From the urine analysis, you can see calcium oxalate crystals and uric acid, so those should be the constituents of the stones. So since he is relieved after dietary restriction, it should not be some hyperparathyroidism or congenital diseases. It was mainly because of his dietary and drinking water habits, okay, or hydration habits. So he was prescribed to decrease salt and sugar. Why? Because you see, if you have so much of salt added to a water, then you are adding sugar to it also, the thing will get precipitated, because whatever amount of solute you are adding onto the water, again it will start getting precipitated. So the more solute in the body, the more will be the chances of precipitation and stone formation. So you're decreasing the precipitating factor or solute by decreasing salt and sugar. Not like totally decrease it, so that your body also requires little bit of salt and sugar. But normally you have to decrease it to a certain level. Okay. More fluids is obviously required. I said you should hydrate your body like anything 4 to 5 liters per day. And then more citrate fruits are good, vitamin C foods are good, less oxalate. See, this crystal here was calcium oxalate and uric acid. Okay, calcium oxalate is formed by calcium combining with oxalate. Oxalate is some constituent which can go through your food also. So if you decrease the amount of oxalate, obviously the calcium won't have oxalate to form with, it will form with some other compounds, okay, which might not form stones. Your um motto is to decrease the stone formation. So calcium oxalate should not be formed. So just decrease the oxalate, so the patient's calcium oxalate won't be forming, and then stones will be decreasing. Other thing is that you increase magnesium and potassium. Okay, so you know that the calcium oxalate and calcium phosphate stones are combining and producing the stones. Okay, so if suppose the oxalate and phosphate is not combining with calcium, and it is combining with magnesium and phosphate, okay, then stones won't be formed. Okay, now you should not think that magnesium ammonium phosphate is also a stone, ma'am. Okay, I said magnesium ammonium phosphate. Urea splitting bacteria, there should be ammonium in that, then only that stone will be formed. Normally there won't be ammonia in the urine. Okay, so normally if there is if there is so much of oxalate and phosphate, if you are eating with magnesium and potassium, all those magnesium and potassium will precipitate with oxalate and phosphate, and it will be excreted through the urine, and then calcium will not precipitate or combine with the oxalate, and so hence the stone formation also will decrease. Okay, then you're giving hydrochlorothiazide and allopurinol to for diuresis, that is increased passing of urine, so that whatever stones are there, it should be flushed off. Okay, and then after all these restrictions, he was totally fine after 2 years. So thank you for watching this presentation. Kindly do like, share, and subscribe, and then comment about the topics which you want me to teach. Thank you so much.